So I want to talk about three particular opportunities that I'm excited about. Doesn't represent everything we're doing at JDRF, but these are things which I think are real, which are imminent, which in fact are in the pipeline today, and for which we have commercial partners, in which we're working aggressively to make sure we can get to people as soon as possible. And I would call these transformative treatments. In my mind, they're treatments, really good treatments, better than anything we have today. Some people might actually consider them a cure, but I'll leave that to the patient to decide. The first is a cell-based therapy, which is basically the encapsulation of cells which produce insulin, protecting them from the autoimmune attack. The second is a drug-based approach, a glucose-responsive insulin. Very exciting approach, which I mentioned a little earlier, which basically would provide a person the ability to take a shot a day or even a shot a week, maybe if it's so successful, that would respond automatically to the body's needs for glucose. And then there's a device-based approach, the closed-loop artificial pancreas. I think that all of these possibilities are realistic in the next 10 to 15 years. But I put an asterisk by that, a very large asterisk. There are a lot of things that have to happen, a lot of collaboration that needs to occur, scientific and industry and JDRF, but I believe that with our support, with an aggressive strategic effort, that all of these things have a realistic possibility of reaching patients in the next 10 to 15 years. And I'd like to tell you a little bit more about that. So let's talk about the cell-based therapy. What we're talking about here is an implantable encapsulation device. Basically a permeable membrane that surrounds cells that can respond to glucose and make insulin. Basically, this membrane allows nutrients to pass and feed the cells, allows glucose to pass and stimulate insulin to be produced, and then insulin can go across the membrane to feed the cells in the body which need it for normal metabolism. The membrane protects islets from the human immune attack. And in a way, it gets around the autoimmune problem. It basically doesn't require us to solve or reverse autoimmunity in order to deliver cells, which would then produce insulin and regulate blood glucose. We could use a number of cell sources for this approach, human cells on one hand, or even pig cells. Both of these approaches are going to be tested in people. Pig cells are being tested today. So in fact, I think we're going to have the cells, and if we have the device, which is a key JDRF initiative, I think we're going to be able to provide an opportunity for this device to deliver insulin independence in people living with type 1 diabetes. So the next therapy I want to talk about is the drug-based therapy, the glucose-responsive insulin, which essentially is an insulin which only works in the body in response to elevated glucose concentration. So when glucose is going up, the insulin works. When glucose goes below a certain level in the body, the insulin doesn't work. So in effect, it's a biological approach to an artificial pancreas, if you will. The idea is that it can be delivered periodically, maybe starting with once a day in an injection, which abrogates the need for testing a blood glucose, counting carbs, giving yourself insulin to cover specific meals. In fact, it only works when it's needed throughout the day. Maybe we could start with once a day and progress towards a therapy that only needed to be administered on once a week. I've had a lot of people tell me if that's all they had to do for type 1 diabetes and they didn't have to worry about blood sugar anymore, they'd consider that a cure. So the third thing I want to talk about, device therapy, a closed-loop artificial pancreas, which is the automation of insulin delivery, basically using a sophisticated set of computer algorithms to take continuous glucose monitor data and to control the operation of an insulin pump. That's what we call the closed-loop artificial pancreas. However, with this therapy, we're going to have incremental progress along the way, which is very exciting. We're going to have initial generations that will use today's pumps, today's sensors, to prevent dangerous hypoglycemic events that can occur when a person is awake during the day. However, more dangerously, oftentimes occur when a person is asleep and unable to respond to alarms, when a person may have gotten too much insulin before bedtime, had too much exercise before going to bed. That represents a danger today that we can fix by cutting off the flow of insulin when a person is predicted to go low. We can also predict when a person's going high, track when a person is going high. In fact, this is an experience that we have in our family. My son, who's 16 years old, doesn't want to have himself identified as the outsider at lunch, so he doesn't pull out his blood glucose meter when he sits down with his friends at lunch. He doesn't want to give himself insulin at that time and basically single himself out in the eyes of his friends or some girls that he's interested in talking to. And so he thinks he'll do it later, but he's 16. He doesn't do that. He forgets, and he comes home and he has dangerous hyperglycemia. We can fix this today by identifying that he missed his bolus, that he ate something, and that he's going high in his blood sugar, and give him some extra insulin that would help him to keep it safe and to basically continue throughout his day without having to always remember. Very transformational, I believe, for people living with this disease, even for adults living with the disease. It's hard thinking about diabetes so much, having to make so many decisions. And these early stages of automation, I believe, will be transformational. So with the artificial pancreas, as I said earlier, we're going to be able to approach this from steps. I believe that within the next 3 to 4 years, we're going to have this first device on the market as a result of JDRF support, as a result of JDRF research, as a result of JDRF regulatory efforts. We're going to have a device which will solve these basic problems of hypoglycemia and hyperglycemia, protect people, allow them to live safer, better, and well with this disease. But we're going to move on from there to more automated devices. The next step might be that you don't have to constantly test your blood sugar. You don't even have to count carbs. Maybe you just tell the pump that you get a small, medium, or large meal. You get a priming bolus of insulin, and then the basal rate is regulated continuously the rest of the way in order to control blood glucose overnight during the other periods of the day when you're not eating. We'll move on to, as we have faster acting insulins, we perhaps add other hormones to a device to make it work more like the pancreas does, which not only makes insulin, which makes glucagon, which makes another hormone called amylin that is required for normal metabolism that type 1 diabetics don't make. In fact, we'll have devices that work more like the pancreas and allow us this level of automation, which might someday allow us not to think about eating a meal in terms of our diabetes and have a device control that all. I believe that in the next 10 to 15 years, we'll make demonstrable, measured progress in devices generation after generation that will start to solve this problem. It won't be a cure, but it'll be transformational for people living with this disease, and it will happen years, if not decades earlier than it otherwise would based on JDRF support. So these 3 pathways, all are in development pipeline. Basically, all are in the process of testing, either in late stages of animals or in humans. That's exciting. Each of these paths does require major investment still, a lot of risk taking, not just from the companies themselves, from JDRF, from the government and academia in some instances where we're still trying to solve aspects of these problems, but JDRF leadership and JDRF strategic management of this landscape of activities is going to be crucial to the potential for us to deliver these. The end result, as we said before, can range from something that resembles a cure to something that's a transformative treatment. At the end of the day, I hope we are in the very good position of arguing whether something's a treatment or a cure. That'll be a mark of the progress that JDRF has made. I need to reinforce that all this is still fraught with scientific and commercial obstacles that must be overcome in order to translate this science. But we are demonstrably in a different stage today in terms of what we can do, what we can say about timing than we ever have been before. And I'm very excited about that. It's the reason I'm doing what I'm doing. JDRF is prioritizing all 3 of these paths and will dedicate the required resources which all of you provide to us so that we can execute our mission. So in conclusion, I'd like to say that defining a cure isn't as easy as it used to be. In fact, we used to think of it as a simple question. What's a cure? Just make it go away. But since we're actually closer to the cure than we ever have been before, we're closer to transformational treatments than we ever have been in our past, it's actually harder to have this discussion nowadays. And that's a sign of our success, that we're standing on 40 years of progress, that in fact we're within line of sight of treatments that will fundamentally transform how people live with this disease, and that some people might actually consider a cure. But all these treatments or first-generation cures, they must be supported by the science, they need to meet the needs of the patient, and they need to be commercially feasible and attractive opportunities. And all these things together must happen in order for us to be successful. But JDRF is working across all these areas today. It's very exciting. These are all on the horizon. JDRF needs a variety of roles in order for us to be successful, and we need the resources to do so. I thank you for your generous support in helping us to execute our mission, and I commit to you that we will be good stewards of the resources and have the most impact on the people who are living with this disease, the people affected by this disease. Thank you very much.